Speakers and content experts with us today who'll give a brief presentation. And following that, the key component of this webinar this evening is the question and answer. You don't hold on to your questions to the end. We are going to basically field the questions as we go along. So please feed your questions into the chat box so that we can itemize them and have them geared to go for the panel discussion that will take place at the end. This is sponsored by the Texas Neurological Society of Business of Neurology course, where we try to provide content to Texas neurologists on those practice, business aspects of the practice of neurology that we don't often get in practice and so forth. So without any further ado, I want to get into this presentation and this lively discussion. We actually had some very good conversation amongst the four of us prior to starting this. So I'm excited about getting into things. First, you'll hear from Dr. Cohen. No, I'm sorry. Stuart is going to start us off. Stuart Black, who everyone is familiar with. He's a member of our board. He's the chair of the Medical Economics Committee and a content expert on coding. So he'll give us a brief presentation. And if you haven't had a chance to read his article that he wrote for Brokers this past edition, I would highly recommend that you pick it up, even though there are a couple of changes that need to be made already, which we'll discuss during this talk. Following Dr. Black, I'm glad to welcome back Bruce Cohen. Bruce is, of course, the director of the Neurodevelopmental Science Center there at the Children's Hospital of Akron, Ohio. Content expert for the American Academy of Neurology, as well as policy makers in DC when it comes to coding. So we're great to have him on board again as a follow-up to discuss the changes that took place on January 1st. So without further ado, I will turn it over to Dr. Black. And again, I would recommend if you do have questions, please feed them into the chat box and we will address those questions in the panel discussion at the end of the presentations. Stu?
Thank you, buddy. Pleasure to be here. Good evening, everybody. What I thought we might start off by doing, since especially I'm sort of a history nerd to begin with, is to do a little bit of a historical background of trying to understand of how we got to where we are, if you will. And I would like to start with a very interesting beginning, which actually was the beginning of Medicare. It turns out that Harry S. Truman never really wanted to be president of the United States. And the reason why he was chosen to be vice president along with FDR was because they needed the Midwest. And FDR never met Harry Truman. He really didn't have a very high regard for him. But Truman consented to run. And he did get elected, obviously. And he met for the first time a week after the election, was the first eyes on eyes that he had with FDR. At that time, FDR was very sick and he was cachectic, looked bad. And Truman's response to his wife was that this guy isn't going to make it and I'm going to wind up being president and I'm not qualified. Well, it turns out 86 days later, he was president of the United States following a cerebral hemorrhage from FDR. During his time as president, Harry Truman tried very hard to pass some type of legislation that would permit senior citizens to have some type of healthcare coverage as much we have today with Medicare. It was a different time, a different Congress, and he was very unsuccessful in doing so, and Eisenhower did not follow through. But when LBJ became president, needless to say, in 1965, Medicare became the law. In honor of Harry Truman, this is a photograph. In honor of Harry Truman, LBJ flew to Independence, Missouri, where Harry was from and lived, and signed Medicare into law at the Truman Library on July 30th, 1965. Harry S. Truman was 90 years old, and his wife, Beth, in the yellow dress behind him, was 90 years old. Hubert Humphrey and Lady Bird are in the picture as well. And that's how it all began. That's how we started with the process that we now know as Medicare. Next slide, fine. It's kind of hard. Can they make those slides any bigger than?
Yes, I'm having trouble with the display.
Okay, because if I'm having trouble, they're going to have trouble. All right, well, anyhow, we'll move on. But
If you move up to the top, I think it should be under display settings. If I'm not.
Yeah, it just says duplicate or swap. That.
there you go.
Does that work?
So let's do a little bit of a chronological background, and this is what I'm going to be talking about in the next 10 minutes. And this is just a brief overview to get us where we are. 1966, the FDA published the CPT code book, and that was again a first. We'd never had CPT codes. At that time, charges and bills, and I remember this, and Bruce and I talked about it, and Bruce's been around long enough to remember this as well. When we saw a Medicare patient, we charged what was called usual and customary. For a lot of you younger people, I know that's unbelievable, but we just charged what we normally charge, and we got paid. No CPT codes or anything like that until 1992, when obviously it became obvious that there had to be some kind of regulation for fees for service and what was expected within a service. Medicare passed RBRVS, and that really sets the standards then for all the things that we now know of as CPT coding, EM coding, and all this sort of thing, which we'll talk about. In 1995, that was the first documentation guidelines, and you can pick them up on the internet. It was a 16-page document, which really introduced the quantitative, I repeat, quantitative measures for history, physical examination, and MDM was introduced at that time as well. Medical decision-making was never, some of you remember, impression, discussion, recommendations. Well, that was how we were all trained, and some people use SOAP, but MDM changed all that, and it also defined time according to face-to-face. Well, unfortunately, also in 95, the examination was a single exam, and ophthalmologists were expected to be cardiologists and vice versa. It didn't work out very well. In 97, there was a revision, which we now know of as the revised E&M guidelines, and that was a 49-page document, but it also has specific examinations, as you know, and it defined the criteria of what we know for the different gradings of problem focus, span of problem focus detail, which we've done for the past 25 years. It also held physicians responsible for compliance with E&M coding, which we'll describe, and also introduced the concept of auditing, if you will. And it really defined MDM in great detail, as did 95, but it really was a qualitative table as opposed to a quantitative table, which I'll get on later. Next slide, please. So the two slides on the bottom are just there for illustration. Please don't try to read the one on your right, because it's just there to show you something. Bruce will go into that. But this is you're all familiar with this. This is from the 95, 97 guidelines. This is MDM. And we were asked with this particular table to define quantitative quantitative measures, if you will, without any guidance at all, because this is a qualitative discussion, and we use this table for all these years. I'm not going to get into how you eventually got into grading all of the different, number of diagnoses and the tests that were done and the risk and all this. And plus, by the way, we've never had to deal with risk before. And it started in Wisconsin. It's called Marshfield Guidelines. And anyhow, we had to do something in order to be unified and being able to give some quantitation to this table. And the Medicare never approved it, but they acknowledged this as being the correct way to do it. To your right is what we'll talk about. This is the table, and these are the guidelines for MDM starting 2021. 2018 was really a very important time because, as you all know, there was a recommendation of collapse of codes from CMS, which would have been disastrous in terms of our economic benefits. And in 2019, AMA, CMS got together and finally defined the time and MDM, or MDM rather, which we'll talk about today. So if I can have the next slide, please. So let's back up again and start again how we got to where we are with the RBRVS. Just to refresh your memory, and if everybody knows this, I'll be a very happy camper, because that means I've taught you nothing and you already know it. But I just want to go over it very quickly to kind of bring us up to date. So the RBRBS was developed for 4 major outcomes, and that's obviously a national fee schedule as opposed to usual and customary. We wanted to have uniform policies for payment nationwide, as well as the development of CPT codes. This is where it all started, specifically in our case, E&M, and a standardized and redefined global services. So this is where we are today, if you will, or I should say as of December and, well, as of today as well, because obviously we just have a difference in how we're coding. Next slide, please. Just to go over again how RVUs are really identified and generated. This exists today. There's 3 components of RVUs. It's called the physician's work, practice expense, and medical liability, with the approximate percentages that are beside them. And all RVUs are multiplied when you come to the bottom line by a geographic cost index, which we all know because you go other states and other places. Even in Texas, there are sometimes differences in the reimbursement because of geographic cost index. I want to define a few terms just to make sure that we're all on the same page and understand this. And again, I hope you know this, but if it just jars your memory, that's a good thing. So what are work RVUs? The work RVUs account for the provider's work in performing procedure or service, and the variables include those things you can read here, from effort, mental and effort and judgment, stress in doing the examination, patient risk, etc. Practice expense is just what it is. It's the expense of running an office or running a practice, whether it's in an office or whether it's managed care or what it might be. And the medical liability, which by the way was added later, is obvious, and that's cost of your professional liability insurance. Cost index then is multiplied to these 3 levels, and you come up with what's a total RVU. Okay, so next slide, please. I do want to really make sure that we understand what conversion factor really is, because as you know, there's been a lot of dealings with conversion factors as of the last few weeks, actually. And the conversion factor is really a way of converting RVUs to money. It's just that simple. It's a multiplier that Medicare uses that applies to RVUs to calculate the reimbursement for the service, and is defined according to specific statute. There's 4 different things. I don't want to get into how the conversion factor is really identified for Medicare, but the conversion factor is calculated annually. And here's the real clue. It has to adjust to maintain budget neutrality. So what's budget neutrality? The term we've all been hearing about in the last few weeks, obviously, and I'll explain why. Budget neutrality is part of RBRBS and basically prohibits CMS from changing its annual budget by more than $20 million a year. So CMS accomplishes this budget neutrality mandate by manipulating the conversion factor, other things as well, but that's a major part of it. We had a conversion factor last year of $36.09, okay? And this year it's up to 34.89, but you'll see shortly, it started out, as you know, I think it was 32.4, I think is what it was, something like that. Now it's on another slide. And that really raised havoc because a lot of specialties would have really had a hard time. And so therefore, payment is the total RVUs times conversion factor. Next slide, please. This is just take a look at it. You can have all the slides. This is basically the difference of reimbursement from a 3609 conversion factor, which was last year, to the 34.89 with the codes that we use for an established patient and a new exam. As you see, the conversion factor initially started out as 32.4. I'm going to tell you, there were major losses in reimbursement from major specialties, even the emergency room doctors, and that caused a lot of havoc. So it was changed right before December 31st. There were some tweaks also with the number of RVUs for 20 and 21, but basically it revolves around the elevation of conversion factor. And you can see that almost all of the, except for the first one, 99202, there has been an increase in reimbursement. Neurology has seen a 7% increase in reimbursement because of this. Next slide, please. Very briefly, I want to refresh your memory also of how we get an RVU, a CPT code. And I want you to remember that the AMA really maintains the CPT code, and they developed the code book. It's not CMS, and they also maintain the RBRBS process. However, CMS defines the CPT documentation guidelines in 95, 97, and now the new guideline, and they define the conversion factor and eventually our payment. When a code comes in and somebody wants a code, it goes through the various stages you see here, from the staff to the advisory committee to the editorial panel, and then to the RUC, which is the Relative Value Scale Update Committee. RUC then sends the recommendations on to CMS, not CMS, this should be CMS. And there are 21 of the 31 members of RUC are representatives of National Specialty Medical Societies. We have a neurology representative as well. And basically CMS, however, does make the final decision, but it's about a 90% success rate from RUC to CMS. Okay, next slide, please. So we're almost to the point where Bruce can take over, because now we're getting to the collapsing of the codes, and that was in 2018. And initially it was 2 through 5, and there was enough balking that CMS finds out, okay, well, we'll just collapse codes 2 through 6. And that means that any code, 99212334, it's all going to be paid at $136 initially, and for your new patients, and $93 for level 2, 3, and 4 for your follow-up patients. I don't have to tell you, especially when you looked at the slide that had the reimbursement, this would have been an enormous hit for neurology, as it would have been for anybody else. Why does CMS do this? Well, there's a lot of reasons that we're not going to talk about tonight, and Bruce and I visited about this over the weekend. But the bottom line is the pitch is that we had a 25-year-old way of doing things. It was outdated. Since EHR came about, there was volume and chart bloat for documentation that was meaningless. Too many level 4 and 5 codes being used, and it just needed to have better, accurate support for the level of the service that was reported. Next slide, please. Well, it turns out that the AMA put together a work group, and the group included the past chairs of RUC, and their names that would be known to those of us who fool around in this business. And they created a 12-member CPT RUC work group that was going to try to do the things that would be an answer to the collapsing of the codes, if you will. There were about 300 stakeholders from national medical specialty societies. It was a very, very robust group, and the reasons for putting it together are listed, as you can see. Number one, of course, to get rid of this collapsing of the codes. They deleted 99201, and this is the thing that we are today. They provided a choice of coding office visits on time or, not and, or medical decision-making. I have a couple of comments before I go any further about medical decision-making. It's my personal opinion that physicians have not done a very good job in understanding what medical decision-making has been going back to 95 when it was first introduced. We really need to know what medical decision-making is today, because that's how you're going to get paid. So Bruce will go into much of this, and we'll talk about it, and with the new definition, if you will, and the way the formulas have been put together. History and physical has been eliminated to be appropriate for the time, and we're neurologists, and we can talk about that, how important is the H&P to y'all. And again, we went to from times that were based primarily on face-to-face with a 50% more time of the evaluation to typical times, which is actually 12 a.m. to 12 a.m. Okay? And the others you can read on your own. And basically, this is where we are today. So next slide, please. Currently, there was a disagreement, if you will, the next slide, between the AMA and the CMS. But these changes went back and forth. And on August 12th, 2019, there was a conference call, if you will, and a lot of things were discussed. Bottom line is that the CMS rather proposed to accept the recommended values for all the codes and the things that you just saw, plus other things. I just listed a few of the things that were on there, and that's where we are today and what we'll be talking about later. Next slide, please. So in summary, then we are at a point where we are now selecting our code, not by the 95 and 92 guidelines, which are obsolete, but instead by obviously total time, and something that has been misunderstood for a long time, that's medical decision-making. The history and physical exam will no longer be an element of choice, although we can talk about how it is to many of us. And time has also been changed. Again, we'll be talking more about what total time means and as compared to what we had before. And with that, I'm going to turn this over to Bruce and he'll pick it up from there.
Thanks, Stu. Really, that was, I've never seen history presented so elegantly, and I really appreciate it. I learned a lot about the history of how all this came about, especially the early history. So what I'm going to do is add a little bit of color commentary to what Dr. Black has talked about, and I think it's going to lead to a whole bunch of questions. So if we can go to the next slide. So there's a word that when I started putting this talk together about a year ago, that just struck me, and the word is pedantic, narrow, often ostentatious concern for academic knowledge. And that's what CPT is. And I just love this cartoon. I'm not going to read it. It's one of those things you either, get and find funny, or it's just too pedantic. But that's what CPT is. And it's a process that is easy to criticize, but it takes in all of what we call the house of medicine. So I'm there as their CPT advisor for the American Academy of Neurology. And, I have to solemnly swear at the beginning of the process that I'm there to represent the American people and American medicine and not neurologists. But at the same time, which is true, that's what we do. But at the same time, I'm going to make sure that everyone gets gored in this process. The cardiologists lost their big money for their catheterizations. GI lost a lot of money when they did the endoscopy codes again. Obviously, we took a big hit for EMG and EEG. So everyone's getting gored in the process, and that's because more and more people are living in the United States. More and more people are seeking medical care. Medical care is getting increasingly expensive, and Congress has set the law that we're not going to pay any. This is it. This is the budget for Medicare. Doesn't matter how many people are on Medicare this year compared to last year. The total dollar, the pie is not going to get any bigger. You're just going to have to share it in different ways. So we can go to the next slide. And I want to talk about going back to that July 2018 event. Out of nowhere, I mean, this was no one in American medicine knew this was coming. CMS announced a plan to collapse the codes to a single payment for either a follow-up visit or a new patient visit. And if you did the math, the payment was essentially a 9920 meaning that the payment was going to be somewhere between a level 3 and a level 4 for a follow-up patient or a new patient. And you would think everyone in American medicine their head would have exploded, but that wasn't the case. The surgeons were saying, well, what's the big deal? We bill mainly level 3s. The plastic surgeons were thrilled with this. And a lot of groups and family practice was okay with it because they were actually, they were sitting at level 3s or level 3.2s. So there was a lot of bodies in American medicine that really were not upset by this. Obviously, all the subspecialists were. And the reason Medicare did this, I really believe, is they never thought that it was going to end up this way, but they really wanted to force medicine's hand in trying to figure out how to solve code creep. Well, what's code creep? For follow-up patients, code creep is the fact that if you do a comprehensive history, which is asking 4 questions, and you do a comprehensive neurologic examination in a patient that doesn't have a weird neuropathy, where you're having to do all sorts of sensory stuff or, posterior column disease, it probably can be done in about 3 minutes. Now, I may not be able to be done well in 3 minutes, but you can get it down in 3 minutes. You can get to a level 99215 for any neurologic problem in follow-up, even if the patient was in the room for 8 minutes. And the same thing with 99205 is that the comprehensive history, comprehensive physical examination only required a complex, not highly complex, but a complex medical decision making. And as it ended up, when this was announced, the incoming president of the American Academy of Neurology called me up and said, how is this going to affect neurologists? And I actually went to the RUC database and pulled out all the codes neurologists have billed in the last year. And as it ends up, neurologist is the #1 utilizer per capita of 99215s and 99205s. So, the finger was pointed at us, number one. Number two, if this really went into effect, we were going to get reamed on it. And so it wasn't just neurology, but all the subspecialties were very upset about this. The other thing is the copy forward feature of the EMR. When you did chart audits, you could literally copy forward your previous note, make a couple changes, not change the medical decision making at all, and get away with up-billing on this. And it was legal, and Medicare wanted to stop it because they couldn't afford to pay for it. So that's why they did what they did. Within a month, American Medicine Organized went to Medicare and said, we don't like the system you're proposing. Medicare said, you guys find a better system, we'll consider it. And then started over a 2-month period, a series of meetings. The first month I kept count, it was 60 hours of meetings that month. These meetings were held at various levels, but eventually we came up with the system that we have today. So we go to the next slide. By the way, I entered American Medicine and as I finished my fellowship in 1989. And so and my involvement in CPT really started in 1995 after the first E&M guidelines were released. And I represented child neurology in the formation of the complete comprehensive neurologic exam. So the reason I think this happened was because Medicare wanted to reduce the 99215s. What they said is the medicine has changed, and what you guys are doing is not answering the needs of the patients. And the needs of the patients are for you to talk to the patients and spend time with the patients and give them what they want. And that's information about the disease, not to do comprehensive neurologic exams. And we talked about the EMR and the audit, the difficulty of auditing it, the code creep, the note bloat. And what when the RBRBS was formed, this term resource-based, that concept was introduced. And that's basically a way of saying that you have to, we want our money's worth out of what you're doing, and we'll pay you for what we believe to be important. And what CMS was saying is we really can't count on you guys for keeping track of your histories and physical exams. So we want you to do them. You got to do them, take care of the patient, but we're not going to pay you for that part of it. And what we are giving back to you as a neurologist is you don't have to document as much. Only document what you need to document to take care of the patient. It also eliminated the need for extensive audits of all this, because any resource-based process requires auditing. And obviously the elimination of irrelevant documentation. I can tell you in the first few weeks, I'm looking at my copy forward notes. I'm eliminating most of the information in those notes. The critical stuff I'm moving over to the problem list, and my notes now are less than a page. So for many of my patients, I'm very happy with the ability to get rid of all that nonsense information. And this is something that we're going to get into a discussion later on, I am sure. Next slide. So I want to talk a little bit about time. Up until now, we've been using typical time, which wasn't typical for neurologists. It was typical for doctors. Okay, typical time was decided years ago, and it was sort of what the RUC had determined was not necessarily average time, but typical for these different levels of services. And basically, they gave us a couple minutes of pre-service time, or as an example, 99214. What was put into there was most doctors spend about 2 minutes before their visit with the patient preparing for it. The office visit time itself and the post-service time, that was all built in, and that's where that 25 minutes for a 99214 came from. And again, typical time is agnostic to the doctor, the patient, the disease, the stage of the disease, the need of the visit. It was a blinded concept. And then we had this, if you spent more than 50% of typical time for counseling and coordination of care, you didn't have to do the history and physical exam or medical decision making. It was they would count that. So what was given to us is this concept of total time, and that's basically all the time the provider spends on the day of service. So the day of service is February 5th. Anything between 12 midnight on February 5th to a few hours from now can count. So that the 20 minutes you spend typing your note, if you're going to spend 20 minutes typing your note, counts as part of that visit time. Next slide. Now, CMS giveth and CMS taketh away. Remember, the typical time for 99214 was 25 minutes. Now total time is 30 to 39 minutes. So if you're going to go just on time alone, you're going to spend a lot more time than typical time was to get that 99214. So yes, we'll pay you for your time, but no, you're going to have to take more time to get to where you want to be in terms of the code level. So again, I'm happy to answer any questions about this slide and the prolonged service code, which is 15-minute increments above 99205 or 99215, but I'm not going to go into the details on this slide. Let's question. Next slide. So where does this put us? Next slide. So what's good? So good is that our notes are going to be more let me just back up. What I'm doing is putting the important elements of the patient's history into the problem list. So I have a patient who has a malignant glioma, and I met a patient when they were 25 years old, and my initial intake note, this is a 25-year-old man who was perfectly healthy until a week ago when he had his first focal motor seizure, and then yesterday he had headaches, and they came in and blah, blah, blah. And then he got his surgery, he got his radiation, he got his chemotherapy. And that has sat from age 25 to now this patient's 45 years old. And I first entered the medical record EMR in 2002 when I was at the Cleveland Clinic. And I have copied forward that note all these 20 years. I've taken that block of information that has now gotten like this and moved it over to his astrocytoma in the problem list. It doesn't exist there anymore. The history that you will read in that note is, Mr. Smith's a 46-year-old man with a malignant glioma. He has no new complaints since his last visit 6 months ago. He's here for a routine follow-up. That's the history. Because he says, I'm here just to get the results of my MRI scan. The review of systems has become relevant because you don't have to do the whole review of systems. So if he said, yeah, he had a GI bleed and is now on Prilosec, I can put that in there. But you can ask the question if you had any medical visits or anything like that, or you can just look in the EMR and find out nothing's happened. The interval history becomes relevant. If you look at review of systems of yourself and your colleagues, unless you're really attentive to it, they become very dated within a couple of years for your follow-up patients. The notes can address the needs for the patient and only those needs for the patient, because you're not chasing stuff just to get that higher level of care. And your medical decision making can be brief. Benefits of support resource-based is that you can pay providers for your time if that's what you like to do with patients and that's what your patients need. And frankly, medical decision making is what neurologists do. We should be paid for that. And it's really more in line of what our patients want out of a visit. Next slide. The bad. Neurologists can't survive on I'm just going to have to change my view if I can, because I can't see my own slides now. Neurologists can't survive on work RVUs alone. And what I mean by that is, the dollar values Dr. Black was showing us are work plus practice expense plus malpractice RVUs. For neurology, most of the codes that we use, about 60% of the total charge is work RVUs. And at $34.89, the average neurologist in the United States bills 4286 RVUs a year. Now that number comes off of Sullivan-Cotter, and so that's a number that, you know, we use in our practice when we want to come, you know, see how hard you work. And we're told the 50th percentile is 4286. If you multiply $34.89 times 4,286, that is $149,538. And that does not pay a neurologist salary plus fringe. That work RVU does, you just can't survive on that. As we move our practices from private practice into hospital-based practices, the reason our salaries are supported is not off of work RVUs. It's really not even off of work RVUs plus our practice expense RVUs. It's off of the downstream. I work with a comptroller in my organization, and we followed. We've done a couple of things. We've taken a headache patient, first complaint of headache as they enter our system, and followed them for a year. We've also done it with epilepsy patients, and then we've looked at downstream from individual neurologists. And the majority of our neurologists bill, around 3,500 RVUs a year. We're a children's hospital. We don't work in the same way as adult neurologists do, but our downstream is 1.5 million. And it was interesting. There's I'm not going to say who, but there's another child neurologist in Texas. He came up with a very similar number with his organization as well. So it's the downstream that supports our salaries. I frankly don't know how neurologists in private practice make it, because they can't capture the downstream. The bad is payment for time alone is just, it's what the patients want, but it's not going to, it's not going to float the boat in terms of being able to support a practice, certainly an independent practice. If you're best practice medical decision making, you can get very prescriptive about it, because you can have a patient with a first seizure, and that's a very common problem. And you can actually write out a prescription for medical decision making first visit. Talk about safety issues, talk about SUDEP, talk about the suicidality with the anticonvulsant you're going to prescribe, and you can put in a dot phrase, and all of a sudden you've got 35 lines of information you told the patient. No way the patient can remember it. So although it can be prescriptive, it gets to be a little bit, if you're writing the same stuff every time you see a patient, is that really unique medical decision making? So so the bad is, we're getting, has to do with policy and payment models, but it can get us into a jam. Next slide. Every time you change something, you get down a rabbit hole, and I think we're sort of crawling into that right now with some of the new the new changes. And finally, the final slide before we start opening it up, is this change is good, but you go first. So the good is that this allows us to take another look at our practices and see what we can do better to meet the needs of our patients. And one of the questions I'm asking my people, we give our doctors 60 minutes for a new patient, 30 minutes for a follow-up patient. That's the standard in most child neurology practices in the United States. Adult neurology practices, some of them are different, some of them aren't different. We have plenty of child neurologists, but I would say 75% are on that 60-30. We have some groups doing 40 minutes for a new patient, 20 minutes for a follow-up patient. There's one group in Connecticut that gives 40 minutes for new, 40 minutes for follow-up. And they did it just because it's easier to run a schedule that way, although they tend to take more for their new patients and less than 40 minutes for follow-up. And then practices are at the 45-15. But what I'm finding with a bunch of certainly my follow-up patients that are rather stable, after 10 minutes, we don't have much to talk about. We're doing a telehealth, and I'm just wondering, I've actually billed more 99213s this calendar year than I've ever billed in my entire career, because my practice, I'm running out of things to talk about. Now, at the same time, for my new patients, I'm still billing level 5 because that's where all the work is done. As we transition from fee-for-service into capitated models, I don't know how many of you folks out there are transitioning. We're going head first. 50%, 53% of our patients are Medicaid patients, 53%. And we're putting 210,000 of our patients into a fully capitated model of care. And with that, you sort of want your follow visits shorter, but you want to be able to touch the patient more times during the year. So, you know, we're looking into, instead of seeing the patient twice a year with the 30 minutes visits, to see them 4 times a year with a 15-minute visit. And that may be better for the patients. And certainly with telemedicine, if it is maintained, that may be a reasonable approach to take good care of the patients. So that's where I think I'm going to end. And the last slide is time for questions and discussion.
Yeah. Well, I appreciate you, Dr. Cohen, and Dr. Black, in taking us through the history up to where we are today and some of the challenges that we are facing today, and undoubtedly will be facing moving forward. I think what we'll do, since we have such a small group, I'm going to take, there are just a few questions that have come across during the course of this meeting. Then as opposed to what we previously discussed, we'll probably just open things up and unmute everyone for a discussion, and that way we can ask questions openly. But I did want to address Dr. Gilmer asked a question regarding this notion of budget neutrality, and I'll let both of you answer. You know, who decides budget neutrality, and as neurologists, as a association, how do we lobby, or who should we lobby about this whole concept, budget neutrality?
Well, I'll start and let Bruce tell you the real answer, but budget neutrality started back with RBRVS, and that was 90s. And you know, these numbers, there are different parameters that go into it. Remember, we had, what was it, Bruce? I'm trying to remember. Was it what was it that they got rid of a few years ago?
Sustainable growth. Sustainable growth.
Yes, right. What was the SGR? SGR.
SGR, right.
And so these are works in progress that are legislative things, but it actually had its origin in the development of RBRVS, because again, there had to be a cap, you know, on some of the expenditures that were anticipated. So that's as I understand it, this is a legislative number. It changes every year. They say CMS comes up with the number, but it's actuarially done, and it really is a modifier that allows a conversion factor, rather, is a modifier that allows budget neutrality to be maintained at right now $20 million a year. Bruce, what are your thoughts?
Yeah, it's a political concept, and the fact is that we're more in debt than we've ever been as a country. Obviously, COVID-19 really, you know, created even a worse situation that was going on, and I really think that Congress looks at physicians' salaries. They look at medical centers. You know, there's certainly some medical centers have gone out of business in the Cleveland, Akron area. Most of them have been bought up by 2 major hospital systems in our area, and the buildings are gorgeous. Parking lots are full. Physicians are making more money year after year. Not every physician, but I think the perception is that this is what and medical expenses are going up outside of Medicare as well. So I think that and I've talked to our folks in BrainPack. Sorry for the background barking. I've talked to our folks in BrainPack, our legislators, and they said this is just not something that we're going to touch because it's going to get nowhere. And been told that over and over again.
Yeah, I'll say I have talked with the TMA, Texas Medical Association, about this as well. Should we lobby or look for some advocacy? And They didn't seem too animate about addressing budget neutrality either.
Yeah, and just sort of getting out of the sustainable growth index, mess that we were getting into has been a big. I mean, that's really, that has been helpful.
Mhm.
Yeah, keep in mind that budget neutrality too is it's part of the process. But you recall, I mean, October, November, December of last year, when the conversion factor was 32.4 or something, and everybody was going to be taking a major hit. What was one of the things that were being pushed by a lot of specialty societies, and that was just get rid of the budget neutrality, because that, in their eyes, and that was the thing that was, really pushing the decreasing of the conversion factor. So budget neutrality is a legislated law, if you will, but at the same time, it's again legislated, which means that it can be changed, but it's going to take a lot to change it. I can assure you. When I don't think that'll be something in the immediate future.
Yep.
All right. Well, were you about to say something, Dr. Cole?
Well, I saw the question about how many 15-minute extended visit codes can be added.
Yeah, I'll let you go ahead and address that.
Yeah, so the answer to that, the way the code was written, is as many as that you want. Remember, your time is more easily audited now, and there's only 24 hours in the day. So, you have to be honest about it, but as many as that you want. Now, what we're finding out, and we're starting to hear this, and we're looking at our bills coming back to us, is some of the commercial payers are limiting you to 1,99417. They're not paying for the second one or the third one or the fourth one. So we're just going to have to keep an eye on that. What we plan to do as an organization is rebill the insurance companies for any shortfall on what they're paying us. But my guess is that we're going to start seeing in our commercial contracts is probably written in. We'll give you one, but we're not going to give you more than one.
Okay.
Eddie, I'd like to propose a question that one of our members who can't be here tonight asked me to ask so that we can discuss this, and I'm going to read the question. The question is, I do have a question that I would like to be answered. Would you submit it for me and then give the reply? Here's the question. If you code /bill for time, does the note have to be blocked /closed /signed off on the day of the service? For example, if I spend more than 30 minutes in a face-to-face visit, but lock the note the day after the visit, may I bill for a level 4 follow-up 99214 based on time? So I did a little bit, this is not an easy question, and I did a little research, but I'd like to have Bruce maybe kind of throw out his thoughts, and then I'll kind of.
Yeah, this is what we're telling people, because what we're telling our doctors, and this is based off of discussions that I've had with other people that understand the way the code was written, is that you have until 11:59 to close the note. Anything done up until then, what the auditors don't want to have to do is search you down on what you're doing on Saturdays and Sundays, because then it really becomes very difficult. So you have till 11:59 to close the note. Anything that you get done before then counts. Anything after that doesn't count, because then then the issue just goes on and on. Well, I did it 3 Thursdays later. That just doesn't count.
So I would 100% concur with that, but let me say this. I told you that I had done some research and trying to define the answers to that, because that, as Bruce defined it, that was my understanding. You have 24 hours, or the end of the day, 12 midnight, if you will, to finish your evaluation of that patient. Now, I did find from certain consulting companies that, oh no, you don't have to worry about that. You can sign off on your note the next day, next week, next month, as long as you only indicate that the actual bill is for that 24-hour period. Well, you know, first of all, I will tell you there is no answer to that question that's cut in stone, because this isn't a question that has any presence in any of the guidelines that we've seen. So whatever answer there is an opinion. I think we would all agree with that. However, I will say this. I was on the board of Blue Cross Blue Shield for a long time. I mean, a long time. And, I rubbed elbows with a lot of friends of mine who were really in the middle of it all. And I can tell you that when you look at all these various insurance companies, and I had a lot to do with other insurance companies, Aetna, United as well, this is years ago, but nothing's changed. Let me tell you who looks at your submissions for a payment. You have a bunch of individuals who are, reviewing your charge. And they have a sheet, they have all these sheets that they're looking at, and it's a templated sheet. And most of these people, without being at all derogatory or trying to be, insulting, but they're not the highest paid individuals in the insurance industry. They're folks who are doing basic, paperwork. Now, let me tell you, you start putting in codes 2, 3, 4, 5 days later that were supposed to be for a particular day, no matter who is, going to tell you it's fine to do, these people are going to look at the date because it's on your computer. That's what they, you have to have some kind of a verification of when this note was submitted. They're not going to look back and see, read the whole note and see whether or not, oh, I'm submitting it for, 3 days before. What I'm trying to say is that it's going to not pass. They're going to decline that charge, saying, no, you had to complete that with the 24 hours. So even if there are consultants who are telling people that you need to, you can complete the note anytime you want, but, as long as you say it's for that day, I disagree with that. I agree with what Bruce said. You've got from 12 to 12. And anything beyond that, you'll probably not get paid.
Yeah, the way the CPT panel looks at this is like telling your kid to clean up the room. And, company's coming over on Saturday night, and it's Wednesday. And, what the kid hears is that room better be cleaned up by Saturday night. And what the parent means is I want to clean up now. It's hard to run after people for all these things.
Yeah, it's not going to happen.
So there was another question for Dr. Cohen. You talked about the true value of a neurologist and in creating downstream income. Can you just explain, explain briefly what you mean by downstream income and how we capture that?
So a brain MRI scan, our institution bills out to insurance companies $4,200 for a gadolinium enhanced scan. They probably get back from commercial payers about $1,100. Okay, that's sort of an average. We'll probably get a lot less from Medicaid on that. But I've had a couple, careers in my career. For the first 25 years, I did mainly brain tumors, and then I moved over to mitochondrial disease. But my biggest brain tumor year, I had ordered 1,100 MRI scans. And 1,100 MRI scans at $500 per scan profit is over $500,000. Okay, so that's what downstream every. So, you could say, well, Bruce, if it wasn't you doing this, ordering the scans, it'd have been some other neurologist. The point is, it'd be a neurologist. That's who was taking care of the patient. Every time I see a new patient with mitochondrial disease, if the patient's under 10 years of age, that patient is going to need kyphosis surgery or scoliosis surgery. And the hospital bill that goes out for those is around $250,000. When you're talking about the 8 to 10 days in the hospital for the patient, the 3 days in the ICU, the blood loss and everything else that goes on, it's a fortune. And what we do as neurologists is we generate tons of money for our employer. If we're working, if we're working in a hospital system, we're working in a system, we're generating lots of money for the hospital system for our presence. That's why we get paid what we get paid. Now, if you're in an independent practice and you don't own the MRI machine and you're just out there seeing patients and doing EMGs and EEG, it's gotten almost impossible to make a living. And what we have to do as neurology is protect that. It's not what I chose for myself, but as soon as private practice is gone, salaries inside the organizations are going to start to tank because there's going to be no place for those neurologists to have the opportunity to go should they want to leave the hospital-based practice. That's what, you know, really concerns me about the practice of neurology today, is the loss of the independent practices.
There's one more part of that too.
Sure.
I'd like to add one thing to that, Eddie. Can I do that?
Sure.
Let me just say this too. There's another, now, you know, right now, all the stuff that we have is for outpatient, and it's going to be inpatient as well eventually, and everything that we're doing, obviously. But let me tell you, when I was chairman at Baylor, one of the things that we also looked at a lot is not only what you generate in terms of what Bruce just said, income for the institution, but it can be reversed. And that is how much income can be saved for the institution by having, for example, a neurologist on a case where a patient might have had a CVA, and instead of getting a CT scan in the emergency room, the next day getting an MRI scan, or a CT and a CTA, and the next day is ordered an MRI and an MRA, and it goes on and on. So we set up a different degree of monitoring where a lot of the tests were duplicated and stuff like this. So the downstream savings that having a neurologist on the case, as opposed to not having a neurologist on the case for many inpatient procedures, is also another means of generating, in other words, paying for your salary.
Yeah.
But that's another way of looking at it.
And as an employee physician, I can tell you that when you look at these compensation models, the institutions do not calculate downstream income and so forth. They claim that it's impossible to calculate. A lot of times it's solely based on RVUs as opposed to really figuring out your worth.
They calculate.
They calculate.
They calculate, because I've been through this, and God, I mean, I was such a bunch of BS I've ever heard in my life. They calculate.
Well, at least they don't.
They don't let you know.
They don't let you know that they do.
I work with a bunch of enlightened administrators, so we did it. You know, we basically looked at how many things I ordered over the course of that year. You know, the consults I ordered, the tests I ordered, and that's where that number came from. Now, again, it's sort of funny money because if it wasn't me ordering it, it had been a partner of mine ordering it. And if there was no such thing as a neurologist, you know, the patient would probably get something ordered anyway. But, you know, we do fine for the people that we work for. Okay, they're happy to have us working there.
All right, so we'll move on to the next question, and we still got a little bit of time to get to these questions here. The first question is there's a question about the Medicare audits being temporarily suspended due to the COVID-19. Is that true? And if it is, does this continue this year as well?
Yeah, so all the rules that were issued in March under the 1135 waiver, originally I think it was a 90-day waiver, and it just kept getting extended during the Trump administration. The Biden administration a week or so ago said all these rules are going to be extended through the duration of 2021. So that basically protects telehealth and also suspended the Medicare audits. It doesn't mean that if you get caught doing something wrong, you're not going to get punished for it. So it hasn't given everyone, you know, free lunches, but they're not going to be audited. Now, what we have seen is from commercial payers is a cutback in some of the payments they're giving us. One commercial payer capped their telehealth visits to level 3. And our Medicaid, one of our Medicaid payers stopped paying us practice expense for our telephone calls. You know, we're all able to bill for telephone calls now. and they just stopped the practice expense payments. So they'll pay for the physician, the $12 we get for the physician fee for the telephone call, but the practice expense they stopped paying for. So again, what we're doing is looking at, it's hard to fight Medicaid policy, but we're rebilling all the commercial. And again, it's really too early. It's only the first week of February. And we just started seeing payments come back about a week and a half ago. So we'll know more by probably mid-March as to what's going on.
As far as payments, we had a delay at the beginning of the year. You all got a letter from on your computer from TMA. I guess it was last week or something like that. And the payments were held for a couple of weeks while some of the processing had to be updated and revised. And now they're supposed to be flooding in, of all the 2-week back payments and everything like that. So that's another thing that, but we don't know what those payments are. Nobody knows what they're getting paid right now. Eddie, you know what it is, don't you? Don't you know?
I wish. We do have a follow-up to Stuart, to what you were talking about earlier regarding the closing the visit. The comment was that it seems like for patients that are seen in one day and closed out that day, you should use time-based billing, but others you should use medical decision making as per the AMA chart. So should that be an issue? If we can't close our note out that day, that we switch back and forth to use a medical decision making as opposed to time. I think based on earlier, it's hard to really say, but any more comments you want to say about that?
In other words, are you asking if there's a time limit on medical decision making, closing out the?
No, close it. The comment was that it seems though if you close it out on that day, you can use time, but if you're finishing your note the next day, you switch back to medical decision making. I think you can still use the time code as long as you just document how much time you spent, right?
Yeah, I mean, you can listen. One of the things that a larger group I know has been doing, and they've got a big group, is they've been actually looking at both. In other words, when a patient is seen, and they're closing out in 24 hours. But when a patient is seen, they're looking at medical decision-making and they're looking at time. Now, one of the things that's obvious is you can get a lot, as Bruce had indicated in his lecture, you can make the same amount of money much more quickly using MDM than you can time. I mean, it's the way it worked out with the thing. But then they're looking at, the reimbursements. The point is that as far as I know, the ruling of closing it out in 24 hours doesn't apply to medical decision-making. Bruce, do you have any information? I think
no, it doesn't apply to medical decision-making. I mean, I can give you an example of, we have a situation today where we had a non-compliant patient, older adolescent, who ended up having recurrent seizures. And, conceptually, all the kid needed to do is take his Keppra. I mean, what the neurologist ended up talking to him about is, first of all, what the neurologist had to do is go review, prior Keppra levels. He had to go into the pharmacy and review how many scripts were filled. He had to go in and review the ER notes, re-looked at the EEG report, looked at the MRI report, making sure that he wasn't missing anything, and talked to the kid about two things. He's going to lose his driver's license, and the risk of SUDEP. Okay, one thing that's going to affect his job, the next thing that's going to affect his life. I said, that's complex medical decision making. I mean, there was enough there on just those simple things that you do reflexively without even thinking about it when you see a patient, that puts it to the highest level of medical decision making. So if you take the time to think about what you're doing with your patients, you may be at high levels of medical decision making a lot faster than you think.
One other caveat to that too, and this is something that was actually, we were talking about it at NEM on our conference call last week, or MEP. But at any rate, you have to also, we have a patient who comes in and they're demented, or they have bad Parkinson's disease, or they have some kind of an issue where they need to have a caretaker and a family member bring them in. And, you know, needless to say, you know, that takes a lot more time to take care of those patients in regards to, you know, trying to obtain your history and getting their exam and whatever you're doing, even if it's pure medical decision-making. But that enters into the medical decision-making process to elevate your degree of complexity. So if you have a patient who, for example, is going to need and require that kind of intensive care through an interpreter or whatever it might be, that actually increases the level of intensity within your medical decision-making process as well. So there's a lot of things that will go into medical decision-making to elevate, you know, because we do these things, and the problem is we don't think about it, and we don't put it into MDM. But if you start thinking about these things and put them into the MDM, your level can go from a 3 to a 4 or a 4 to 5, even depending on what it is. It's, things we have to learn. It's a learning process.
And Stuart, I think you addressed the last question, which was about how do we justify higher levels of MDM, and that's exactly what I've been doing, is just making my assessment and plans more into a narrative, talking through that seizure patient and SUDEP and why I'm making a decision making, in hopes that rather than just leaving it up to bullet phrases and so forth, just really explaining and documenting as a way to fully explain your decision making.
There's another way you can do this too. I'm not trying to game the system, but you know, I've been doing this a long time. So when you look at the 95 and 97 guidelines, I think it's on page, I wrote it down so, but I don't know where it is, on page 35 of the guidelines of the second set 97, I forgot. Anyway, there's something there called the table of risk. And if I asked all of you, those of you who are friends with mine, and Bill's shaking his head, he's heard me say this a million times, but you know, very few doctors really even know what the table of risk is or ever heard of it. But the table of risk is in these guidelines. Well, guess what? When you look at, here it is here, when you look at the new guidelines, this is in 2 pages, but it's the new chart for MDM. Almost all of it is taken off of the table of risk that was in the 95 and 97 guidelines. Mm-hmm. We theoretically should have been doing this for a long time to begin with, but it's been made better because some of the general terms such as what's, you know, mild or moderate and all that, it's been made more specific, but this is not new. This is the same thing we've really been doing, only it's been made more understandable. And if you understand the table of risk, and you know, and you say, for example, you're treating a patient who has anti-epileptic drugs, all right, or any drugs, Parkinson, you name it. And the patient comes in and you're going to have to monitor, you've got them on something that, or even say a monoclonal antibody for something, you're going to monitor them. Now, you can't monitor by improvement. So in other words, you can't say, well, I'm monitoring the drug to see if they're better, or monitoring with your own note. That's not monitoring. I have to get a, you know, CBC or a comprehensive profile every so often to be sure the liver is doing fine and stuff like that. That's what we've been doing all these years. That is a way then of documenting that you've done that, and that increases it can increase your especially if you have other things that you're adding to it. What I'm trying to say is, I'm not saying you game the system. What I'm saying is, we have as physicians been doing so much for so long that we've just done because that's what we've done. Now, if we take all those things that we've been doing and simply document that we've been doing them, then I think you'll see that a lot of the levels can be higher than you would have anticipated, not by gaming the system, but by just documenting what you've done.
Yeah. And I would say changing neurologic status puts you in a high-risk situation. Adding any anticonvulsant drug, even if it's not for seizures, you know, add gabapentin for a diabetic neuropathy, Topamax for, you know, migraine, carries with it the risk of increased suicidal thoughts. And that's something I mention to my patients every time I prescribe those drugs. Talk about suicide, that's level 5, almost always. So without, and you can do it without scaring patients.
Oh yeah, absolutely. We've been doing it. It's just we don't document it.
Great.
Well, we are at right at about an hour and 15 minutes. So, and I don't see any more questions here. I want to make a few comments and then I'll turn off any last minute comments from the panelists. First of all, thank everyone for attending this evening. And if you enjoyed this or if you found it helpful, please let Kai and let us know as a TNS board so that we can continue to provide meaningful content for members as a member service. So again, if you thought this was helpful and you want to see another coding seminar in a month or two, let us know. We are here to create programs that best benefit the members. So with that being said, I'll turn it over to Bruce or Stuart if you have any last minute comments.
Bruce?
I just listened to the last 2 days about changes coming on board to inpatient coding. So my head is spinning. That's what I've been doing. I've been at the CPT meeting. It was supposed to be in Tucson, but it was sitting right here in this office. I've had it with CPT for the week. I'll pick it up on Monday.
I just, my only comments are that this is a new way for us to be able to record and document a lot of the things that we've been doing. The issues are, everybody's been complaining about how hard it is to document all the things we've had to document in order to get to a certain level of care. Well, the reality is, and I mentioned this several times, we do a lot that we don't document because we've just assumed that's how we're supposed to do it. And now we're being asked to document it. That's what medical decision making is all about. And it's not something new. It's just something that we have to learn. And I would ask you to really, oh, by the way, to ask you to go and look at the both the AAN, and Bruce has done, I bet you 10 to 1 most of these. Some wonderful stuff on the AAN website on everything we're talking about and how to understand the new table, et cetera, and to go to the website, the AMA website. They have some tremendous, they even have some great videos of really great people who are talking about this. And you just have to learn how to understand what we're expected to do. And hopefully this will be some type of an advantage for us. And we'll just have to wait and see. It's a moving target right now. That's my comment.
Yeah. So there was one more question about open notes. This is a federal standard, so it's not like anyone's asking you your opinion whether you want it or not. We were really concerned. I wasn't so concerned in my practice because it's people with brain tumors and mitochondrial disease. But if you're talking about metabolic syndrome and patient has a BMI of 40. And you write down morbidly obese, you're going to get complaints. And that's true. And we had teaching seminars on how, and again, we're a children's hospital. So, we don't have the same issues as adult patients would have with some of these sensitive matters. But, if someone puts down there, suspect malingering, that's your patients are going to see it. So,
and you gotta watch out for acronyms. You don't want to say patient SOB. Yeah. We know it is shortness of breath, but there's another interpretation of that as well.
Yeah, or shorthand for follow-up is another,
Yeah, I once had a patient who called me and was very upset because along with her dizziness, I called her giddy. And she said, I am not giddy. I am not giddy. I don't know if I'm insulted by you saying it. So, yeah. All right. Well, I think we will close on